Okay, so good evening, everyone. So it's a great pleasure to welcome you all. Updates on hepatocellular carcinoma management meeting. So I would like to invite Dr. Mithun sir. He's a director of hepatology AIG Hospitals Hyderabad to give his overview the webinar and to give his first talk, sir. So it's over you.
Good evening, everyone. So today we have organized this updates in hepatocellular carcinoma management. We are thanks to our academic partners. So today we will try to cover in the next 2 to 3 hours the entire gamut of ACC. So which will include right from screening of ACC, how do we diagnose ACC, to we have included uh, intervention radiology as well as radiation oncology, and also end up finally with uh, the hope for the patients who don't have any hope, that is immunotherapy, which uh, our speakers will be talking. We'll also be having some case-based discussions, which will be quite captivating for the audience. My job is to talk about screening and surveillance of ACC. So when we talk about screening and surveillance of hepatocellular carcinoma, this is something which is very important because majority of us see the patients quite late in the course of the disease. And so we have to develop a strategy so that we get these cases early and we can save lives. So this is the outline of our discussion. We have to understand that diagnosis is different and surveillance and early detection is something different. So when we talk about the epidemiology of hepatocellular carcinoma, it can be divided into different zones. There are countries where the incidence of ACC is very high. This is when it is more than 20 cases per lakh of population. Countries like China, Japan, where the incidence of ACC is the highest. Then between 11 to 20 cases per lakh of population, it's the moderately high incidence zone. If it is less than 5, it falls into a low incidence zone. Countries like Australia and New Zealand and Western Asia, Africa, Central America are the ones with low incidence. And then we have the regions where there is intermediate incidence of hepatocellular carcinoma. Now, when we talk about surveillance, what is surveillance? Surveillance is to detect a disease before it has hit the patient. That is, it is to detect before it goes into symptoms. So when is a surveillance considered justified? Not all diseases are undergoing surveillance. For example, if I say I will screen the entire population for fatty liver, that is not considered as a cost-effective surveillance. How do you define surveillance? So different authorities define surveillance in different ways. The ASLD believes that it is considered to be effective if it provides an increase in longevity by at least 100 days, or if the cost is less than 50,000 US dollars per year of life gained, it is considered to be a cost-effective surveillance. Whereas the European Association of Study of Liver Disease describes it as an incidence of greater than 1.5% per year. Any disease which has this incidence warrants a surveillance irrespective of the cause and irrespective of the cost or the increase in longevity that it can cause. So ACC fits into all these definitions, and that's why surveillance of ACC is being done. The next big question that people ask is, does surveillance program help for ACC detection? Where is the data? So data is old. So this is a very old study in 2004, which was a population-based randomized control trial where they used surveillance ultrasound and alpha-fetoprotein measured every 6 monthly versus no surveillance. It included around 18,000 patients from urban Shanghai, and these were patients with prior hepatitis B, and regardless of the presence of cirrhosis. So we can see that in this study, the adherence to the program was very suboptimal. Only 55% of the patients adhere to it, but yet the mortality of ACC decreased by 37% in the surveillance arm. There was another study almost at the similar time where they tried to use only alpha fetoprotein as a marker of surveillance, and they included high-risk male patients who were hepatitis B surface antigen positive. This study, however, did not show any benefit. Since then, there has been multiple studies that have been shown time and time again that there is a surveillance benefit on doing a routine ultrasound in patients who are on high risk of development of ACC, more so in patients who have a cirrhotic liver. Now, the question is, who undergoes surveillance? Now, we have different guidelines which have different recommendations for undergoing screening. I've put in this table the EASL, ASLD, and the APASL guidelines. So in patients who are cirrhotic Hep B, Hep C, or patients with cirrhotic NASH or alcohol use disorder, the child A and child B, it's very clear, everyone believes that they should be under surveillance because we can save lives, we can increase the disease morbidity as well as mortality. But in patients of child C, the EASL and the ASLD believes that surveillance is only justified if the patient has been listed for transplant. Though this is not the case in our practical real-life scenario, and the APASL guideline is quite in tune with this, which says that in patients of child C also, we can do surveillance. Why precisely they feel that surveillance may not be beneficial in child C is that if we have a small ACC, they are most of the time not eligible for any loco-regional therapy because they fall into BCLCD. But with the advent of new agents and new therapies, many of these patients do have a downward shift. They can change from child B to child A and C to A. In diseases other than Hep B, Hep C, NASH, and alcohol, like in PBC, Wilson's, and autoimmune hepatitis, also, if there is cirrhosis, they recommend a surveillance program. Now, the debatable part are the non-cirrhotic Hep B patients, the patients with Hep C, which are not yet developed cirrhosis, and patients who are having only fatty liver. For hepatitis B patients, we can use one of these calculators like the Page B calculator, which includes platelet count, age, and gender of the patient. And anybody with a score of greater than 18 is considered as a high risk because they have a 17% risk of development of ACC at 5 years, while those with a score of less than 9 have a 0% risk at 5 years and can be not screened. Coming to patients with NAFL, the EASL and the ASLD puts this recommendation as very weak because to surveil all these patients of NAFL would be a huge cost. APASL believes we can screen a certain category of high-risk patients like those who had the family history of ACC or who had advanced fibrosis are the ones which we can screen. So to summarize, non-cirrhotic Hep B, F3, ACV, and NAFL with fibrosis, many societies do not recommend, and yet we try to screen those high-risk patients like a Hep B with a family history of smoking, of ACC, smoking, and alcohol use, which can paradoxically increase the development of ACC. The ASLD guidelines, if you remember, says that smoking and alcohol increases the risk of hepatocellular carcinoma by 9 times. And also, we may have to change our surveillance strategy based on from which part of the world a patient is. For example, an Asian male hepatitis B carrier above 40 may benefit from surveillance because they are a high risk. Similarly, an Asian female Hep B carrier above 50 years and those with family history of ACC are the ones which can benefit. So does African and North American Blacks who have developed ACC at a very young age. Now, how do we do a surveillance modality? The EASL believes it's a 6-month ultrasound only, though they're recently changing the guidelines to include again the alpha fetoprotein. ASLD says it's a 6-monthly ultrasound with or without AFP. The APASL is what we follow because we believe the alpha fetoprotein and ultrasound are both complementary to each other in the surveillance program. So how good is an ultrasound? So how good an ultrasound is depends on how good the person sitting behind the machine is. A person without having a good interest in liver will possibly miss majority of the cases of ACCs. This was a very interesting study. We said that 20% of ultrasounds which somebody has done are considered as inadequate for surveillance because they did not do it properly. Surveillance ultrasound definitely has a sensitivity of 94% and a specificity of 94% again for detecting ACC tumors before they are presented clinically. But how do we interpret an ACC? So if the radiologist is 100% sure that there is no focal abnormalities, or he has found some definitely benign lesions like a cyst, we call it as a negative surveillance or ACC screening. However, if the lesions are less than 10 millimeter that the radiologist is not certain that they are benign, we call it as non-diagnostic. And any lesion greater than or equal to 1 centimeter on an ultrasound in the background of a high risk of ACC, more so in cirrhotic, should be considered as a positive interpretation of an ultrasound and needs further cross-sectional imaging to diagnose or detect early ACCs. So ultrasound definitely is a tool which has its advantages because of its non-invasiveness, it's cost-effective, it's accepted by the patient, but definitely, yes, many of these isoechoic lesions are missed. It depends on the expertise of the operator. And in a cirrhotic liver, where the nodules are present, it is sometimes very difficult to detect unless the person is well versed to seeing liver ultrasounds. Coming to alpha fetoprotein. So alpha fetoprotein is considered as a seromarker for detection of ACC. But keep in mind that it is more of a diagnostic tool than a surveillance tool because of the suboptimal performance it has as a surveillance tool. For example, in patients of Hep B and Hep C with cirrhosis, there can be very fluctuating levels of alpha fetoprotein. So if we have a 1 point time of AFP levels, we may be missing. And we also know that around 10 to 20% of early ACCs only have raised alpha fetoprotein. It also depends on the cutoff of alpha fetoprotein that you are taking. If we take a cutoff of 20 milligram per ml as positive, the sensitivity is 60%, specificity is 90%. But the moment you take a higher cutoff like a 200, it becomes more specific, but the sensitivity falls to only 22%. So a longitudinal change in the alpha fetoprotein may be both more sensitive and specific than a single point alpha fetoprotein, and that's what we normally do in a real life scenario. So as we increase the level of alpha fetoprotein, the sensitivity decreases and the specificity increases. When alpha fetoprotein is combined with an ultrasound for detection of a lesion, it can detect an additional 6 to 8%. But again, it leads to a 7.5% of false positive rate. And this actually leads to an 80% increase in cost for each ACC diagnosed because we can end up doing unnecessary CT scans and MRI. AFP alone has a 5% false positive. Ultrasound alone has a 2.9% false positive. Both combined will have a 6 to 8% of false positive rates. So therefore, alpha fetoprotein is still considered as an inadequate screening tool by the EASL guidelines for ACC, though it is a very good diagnostic tool in patients who are secretors of alpha fetoproteins. Other biomarkers like DCP has been associated with portal vein invasions and advanced tumors, and so it's unlikely an early marker and is possibly not any more useful for detection of early ACC. Similarly, the GALAD model, which is a very promising model, and with the latest data coming, which has came up last year, its sensitivity of detecting early ACCs is around 73% with a specificity of 86%, which again is not as high as it's expected in a screening or a surveillance program. So many people argue, why not do a CT scan or an MRI as a surveillance tool? So there's no data to support the use of multi-detector CT or an MR. CT definitely no, because of the high risk of radiation, MR because of the high cost. The only exceptions are the patients on the transplant waiting list where CT and MRI are already used. And if we have a patient who is obese, who has chest wall deformity, or whom the ultrasound cannot be done because the radiologist was not able to visualize properly, in that case, we can use. There is a significant role of using an abbreviated MRI now. Many centers are using it. It takes lesser time and it can detect early lesions. But MRI also has a low false positive rate of around 3% only. The next question is, how frequently do we do a surveillance? Do we do it at a 3 months or a 6 months or a 1 year? Definitely not 1 year, because studies have shown that uh, if we do it as a yearly screening program, the sensitivity falls to only 50%. There was no difference found between a 3 months versus a 6 month surveillance program, but the Japanese guidelines believe it should be a 3 month surveillance, probably because the incidence of ACCs are much higher in that part of the country. So it depends on the incidence in the target population and also the mean doubling time of ACCs. What is more important, I believe, is to convince this patient to come for a repeat scan, which we call a recall policy, which is crucial for the success of any surveillance program. So if I find a nodule of less than 1 centimeter, we should be able to follow them up in possibly lesser than 6 months. Like a EASL says, you screen every 4 months for a year and 6 monthly thereafter. The ASLD is even more cautious. It says you follow them up 3 monthly. But if, yes, any nodule that is more than 1 centimeter, we cannot rely on an ultrasound or an abbreviated MRI, even if it is a false negative. We have to go for a cross-sectional imaging. So possibly in the near future, the screening program might change. It may be that not one size will fit all. So if we have a cirrhotic Hep B, we might do a screening ultrasound and an AFP. If there is no cirrhosis, we might just avoid a screening. If we have a fibrotic patient, we can use one of the ACC risk calculators and then divide these patients into a high risk, medium risk, low, or a very low. The low risk group may not require screening, or we might have a screening strategy 1 for low risk, like let us do an alpha fetoprotein every 6 months with an ultrasound, maybe a screening strategy 2 for a medium risk, where we screen a little more frequently, or maybe in the high risk, we can do a cross-sectional imaging like an MRI once in 6 months. These are all risk-based surveillance strategy, which are still in the pipeline, but not yet approved by any guidelines. But this is what the future looks like, because every tumor missed is a life loss in the end. So with this, we might have this new strategy of ACC calculators, which many of us have started using in our real life practice. Our entire aim of this entire talk on surveillance is to give the message that surveillance helps, that surveillance can detect early ACCs, surveillance can lead to prolongation of life, prevent the mortality and morbidity associated with ACC, and possibly many of these tumors can be detected at a stage when it can be a curative treatment rather than a palliative care. Novel biomarkers are coming up in the market, like people are using circulating free DNA, liquid biopsies. There are panels like the WACO panel or the Gallup score, which I've used. Then there is a combination of circulating tumor DNA and a Fuji WACO panel combined. But none of this have been successful as of now for the early detection of ACCs, which we are coming up or discussing today. So abbreviated MRI is something which is more exciting. Here we take MRI sequences relevant to ACC. The T1 axial contrast phases are taken. The sensitivity and specificity are found to be similar to a normal triphasic MRI. Data are emerging and people are using it. It is considered to be safe, time-consuming for the radiologist, non-invasive, and a cost-effective screening tool. So as the cost increases, the effectiveness increases, but there will be many cases where there will be some harm because we will end up doing unnecessary screening. With this, I would like to stop here and hand it over to the next speaker to give the insights on the management part of ACC. Thank you so much.
So thank you so much, Dr. Nitin sir. And I would like to invite Dr. Surjana ma'am
Right.
to her talk ideal candidate for SBRT. So it's over to you, ma'am.
Can you hear me?
Yes, ma'am.
Okay. I will just share my screen. Can you see my screen?
Yes, ma'am.
Yeah.
Make it full screen.
Yeah. I'm doing. Give me a moment. Yeah. Hello everyone. My name is Dr. Sujana. So today I'll be talking about how to identify an ideal candidate for SBRT. So my flow of presentation will go on like this. I'll be talking about comparison of BCLC 2004 versus 2022 and trials comparing several liver-directed treatments versus SBRT, MDT-based process flow, post-SBRT imaging, and because upcoming trials and evidence comparing different modalities and conclusion. So, as opposed to BCLC 2004, which never mentions about anything except for just ablation, resection, transplant, and phase. So, if you look at the BCLC 22, almost down the line, it's about 18 years, but still there is no mention about any active yeah, but in fact, the systemic treatments have considerably improved with Etizo and BEV. So if you look at the retrospective SEER data comparing different modalities, one of the first established local treatments was ray-frequency ablation and magnetite ablation. If you look at the comparison between those two, of course, we don't have any RCTs for comparison, but it's just a retrospective SEER data. So there is a lot of there's a superiority showing that RFA is definitely better than SPRT. But if you look at in a granular level, there is lack of granular level propensity score matching in this, and also there is no accounting for hepatic dysfunction, and also there is no account for locoregional relapses after radiofrequency ablation. And also, almost 25% of SBRT patients had low or unknown radiation dose in this particular paper. So this is a very interesting paper which usually our IR colleagues keep citing. And also, if you look at the SEER data cost effectiveness, there is no difference in 90-day hospitalization or there is no difference in overall cost effectiveness. So, if you look at a multivariate analysis, any tumor which is more than 2 centimeters, definitely SBRT has fared well in this particular scenario. So, in that regard, I would like to conclude that size definitely matters. So, again, if you look at SBRT versus RFA, there are a lot of meta-analysis. Local progression is definitely better with SBRT, but overall survival at 2 years is better with RFA because of the tumor burden or liver profiles, so no lot of heterogeneity is there in trials which were enrolled. So a well designed randomized controlled trials will definitely have to be required before we tell that one treatment is superior over the other. So if you look at the NCCN guidelines, even the latest guidelines, this is an old presentation of mine, but even if you look at the old latest guidelines, they clearly mentioned that there is a role of external beam radiotherapy in patients who are ineligible for transplant upfront. So everywhere in hepatocellular carcinoma, everywhere the role of SBRT or EBRT has clearly been mentioned as non-local treatment. But like I said, order doesn't indicate preference. So the choice of treatment modality depends on extent, location, a lot of other factors like hepatic and institutional capabilities to carry out the procedure. So we have got a lot of comprehensive guidelines from different from major organizations like ASTRO, Korean, Japanese, Chinese, and also European guidelines. So most often than not, we usually follow the Far East guidelines because of the closeness in tumor biology and tumor profile and also the patient profile. So now let's quickly go into the PSVRP checklist. First and foremost, we need to check the performance status of the patient, do a routine blood serum AFP, liver function test, get to do a CPS score, MEL score, ALB score, and also make sure to look for size and feasibility of SBRT by doing proper to rule out extrahepatic disease. You can probably stick with CT chest and CT abdomen, or probably just a comprehensive PET CT. So let's look at a case scenario wherein the patient presented with abdominal distension. He's just 45 years old, generalized type of pain, and is also a known alcoholic CLD. The pain is being relieved by opioid medication and antispasmodic medication, and his performance status at presentation was 1, it just was present, and there is slight tenderness. So we got a baseline thinking that there could be something sinister going on because there's already a known case, established case of CLD. We got an MRI imaging which was showing almost around 2.1 centimeter lesion in the liver along with portovian tumor thrombus. So this is the arterial typical vascular hallmark of HCC. So now let's look at the treatment options. Upfront surgery is ruled out because of the portovian tumor thrombus. In view of the size and portovian tumor thrombus, again, the RFA and microwave is completely ruled out. These days, I don't think anyone is doing RFA anymore. So even TACE is ruled out because of portovian tumor thrombus, because TACE is contraindicated, and TARE because of financial constraints, TARE is also ruled out. So we're just left with one modality, that is the SBRT. So we've given a considerably good amount of dose for this patient. We've treated the primary with the portovian tumor thrombus, and we've given a dose of 50 grain 5 fractions with a DIBH technique. And there were no associated complaints, and he went on to take lenvatinib, but he was not complained because of various issues, because of side effects, and because of complaints, and because of financial toxicity and other things. So post SBRT, even though it's very early to do imaging or lab parameters, but in view of because this patient we considered it to be a bridge for transplant, so we had to repeat all the imaging and blood parameters. So definitely there is a significant fall in serum AFP if you look at it. So if you look at the PET scan image also, there is a definite response for SBRT in this particular patient. So if you look at the images, you can clearly appreciate the difference between the lower and the upper images. The definite tumor thrombus, which is FDG at baseline, is completely vanished. So these are the game images. So previously, the saying is like this: if you have a BCLCC advanced stage, you just go ahead with just therapy. That used to be the initial guidance. The current BCLC also kind of endorsed the same. But I think we are headed in a completely different direction. Even though the systemic therapy has to play a comprehensive role in managing HCC, now local treatments are also as important as systemic treatments in keeping the tumor at bay. So when do we decide? So you have to definitely be a child A. Of course, up to select B7, we can go ahead. P's have to be 0 to 1. PCLC stage A to C. C is only for portal invasion and not for extrahepatic mets. So the maximum tumor size previously our cutoff used to be very, very stringent, up to 6 to 7 centimeters, but we have kind of extended our cutoff to 10 centimeters, provided if you have an adequate liver reserve. And the lesions shouldn't be more than 3 intrahepatic foci. Like I said, adequate liver reserve of more than 700 cc, no extrahepatic disease, no history of abdominal radiation or concomitant active viral infection. Looking at the contraindication, patients with child B7, intractable ascites, active viral hepatitis is definite contraindication. Once your active viral hepatitis subsides by antiviral medication, then definitely yes. History of hepatic decompensation and low platelet count and closeness to the luminal GI structures definitely is a contraindication. So of course, there are different comparative modalities as to which is better than what kind of modality is better. So there have been a lot of studies on patients who are having portovian tumor thrombus. So now quickly looking at post-SBRT imaging, you usually look at the tumor and the normal liver. So we need response evaluation to know the response to the tumor. Whenever you're sending the patient for transplant, you need to have a clear communication with the surgeon. If the intention is bridge, you are essential to know what happened to the tumor burden. And also, just in case if the tumor is progressing, you will also understand whether the tumor is progressing or not. Any untreated tumors which are kind of in different stages of maturation, you'll be able to pick it up. Timing of evaluation, you can do, ideal timing of evaluation is usually after 9 months. But just if your intention is bridge, you can always do it at 6 months. 3 to 6 months is also reasonably okay time, but I don't think you will get adequate information at 3 to 6 months just on a CT or an MRI, because it will still be under the process of death. The cells will be under the process of dying. So I don't think it's an ideal situation where you can do imaging at 3 to 6 months. Again, imaging criteria in the same hallmark criteria like any HCC baseline imaging, persistent APHE. If you still have persistent APHE at rim enhancement post SBRT, please don't believe that report. If you still have a doubt about the response, please put in a needle and see whether it is viable or necrotic. So again, these are the different stages of at baseline. You could see the enhancement slowly over a period of time. At 3 months, the enhancement has clearly come down, and at definitely 12 months, there is a clear-cut evidence of necrosis. So now we just look at TERT resist versus M resist. So previously, the typical old age conventional technique of resist does not apply here. We have to apply something called M resist, where you just look at the enhancement component rather than the entire size of the lesion. So again, these are all how to clearly look at equivocal, non-viable, and viable tumor. So if your radiologist is really good, they'll help you in identify which is viable and which is non-viable. To summarize, if you have an observation at surgical margin, yes, then definitely you need a LIRADS treatment response algorithm and take it. And if the patient is fit for local regional treatment, go with the local ablative transcatheter or EBRT. So hot off the press, I mean, it's not so hot. When I prepared this presentation, it was just kind of talked about so much this trial at the RTOG 1112, which kind of gave SBRT a leeway in macrovascular invasion patients, which definitely shown an improvement in overall survival. So even better PFS and time to progression. Of course, there is a latest trial comparing PACE versus SBRT, but in view of poor accrual, it's closed early. So, but still there is a trend of showing that SBRT fared well in whatever patients. Of course, I don't think that's the right way of comparison, but the trend is always there, even though it's not significant. So this paucity of RCTs and good evidence, of course, TACE also gets stayed apart after the tear has kind of come into picture. There is also kind of a different modality, but still a radiation, but you use yttrium of a treatment. So this is again randomized phase 2 study SBRT versus phase with as a bridge to transplant. So there are a lot of other, one of the first great pieces was the last retrospective study by Sept et al. Showing more than 4 times local control with SBRT compared to TACE. So there's also an interesting signal with SBRT IO combination. We are also kind of participating in a trial these days. It's still at IERB. So mostly will be part of a very interesting trial with SBRT followed by Atezolizumab or Atezolizumab followed by SBRT. We've been treating, but not on a trial basis. We discuss in MDT and then we are kind of taking it forward. So again, there is a Comito phase 3 trial, which has definitely shown a better response with SBRT, especially with respect to local control. So why are we so confident about SBRT? Because we are very, very extremely certain that we'll be able to deliver a BD of 100% with certainty to the 100% of volume, because we know what we're doing, we are seeing what we're doing. And all patients should be counseled on the truth as far as we know it, and local control is not even close to other modality. You have already seen the Comito trial and the Sapir et al. Paper, where the local control is definitely 4 times better or 10 times better in the Comito trial. Of course, there is no voice difference to see. We are talking only about SBRT as a local modality. We are not talking about SBRT as a systemic modality, but I don't think we should be comparing apples with oranges. Still, in patients without MVI, I suspect MVI might tell a different story, but still, in RTOG 1112, we kind of heard a different version of the story. Now that we are no more using sorafenib at any point, we kind of moved to the immuno era. So, but still, I think there's a lot to be done in future in combination with SBRT. And to conclude, SBRT is new and data is definitely encouraging. But without any RCTs, any rigid stance is the issue is dogmatic. But still, a lot of case reports, case series. We need a multi-disciplinary meetings and multi-institutional collaborations to pull up more and more patients to run a proper randomized control trial. But there are robust retrospective and phase 2 trials. Usually, it is preferred for large subcapsular and perivascular tumors, where a TASE or RFA is kind of not feasible, or a microwave ablation is kind of contraindicated. Any LDT has contraindication, so does SBRT. So we just have to discuss in MBT and take a decision. Case selection is very, very important based on the relative merit and demerit of all the modalities. So synergy with IO is definitely the future what we are looking at. So I hope in future we'll be accruing more and more patients and probably synergize with immunotherapy with Edizo and all. So thank you so much for your patient hearing. Thank you. If you have any questions, I'll be happy to take them.
Okay, thank you so much. Is there any question? So move ahead for the next session. So next sessions is this session sponsored by Roche, and I would like to invite Dr. Sanath sir. So it's over to you, sir.
Thank you, Geetika. So, I think my slides are visible and they are moving. I am audible. Good evening.
Yes, sir.
Good evening, all, and thanks, Roche team, for providing me this opportunity. So today we will discuss about the managing unresectable HCC. Can we take the bull by the horn? So none other than other cancers. If you see, this is the only cancer where definitely multidisciplinary tumor along with molecular tumor board has a role. So where different specialty person should be needed, then only we can give a good treatment. So one is physician side, one is the patient side. So everything we has to match. So there should be medical oncologist, surgeon, hepatologist, gastroenterologist, surgical gastro, radiation oncologist, intervention radiation oncologist, and missing in this is pathologist. So everyone should be there, and a transplant physician. And along with that, patient side, we have, if you see, preference, trial availability, COMAPs, age, socioeconomic factors, transplant resection, target therapy, best supportive care, local regional therapies, cancer immunotherapies. So my patient is actually, before that, these slides are given by Roche. My patient is XYZ, 62-year-old male with a history of diabetes, hypertension, and dyslipidemia, CAD. So all the metabolic syndrome and their complications, NASH-related cirrhosis, and HCC. So typical Western countryside HCC. So HCC diagnosed in Jan 2021, 6 centimeter mass in segment 5 and 8 on the triphasic CT. So, so if you see here, the investigations are AFP 1054 and triphasic CT. This is the triphasic CT, and the CTP score, child target pug score is B7, so grade B, and BCLC stage is also B. And so as such, we have patient underwent TASE twice at the gap of 3 months. So 2 times TASE he underwent. Then there is a good response. 5 centimeter lesion became 2.8 centimeter big, 2.8 centimeter. Then the 2 centimeter lesion has become unchanged. Then on evaluation, there were no esophageal varices, no ascites, encephalopathy. So the CLD is compensated CLD, and child target pug score is 6. So it has improved from child target category B to A. So there is LFT improvement. There is also reduction in the size of the lesion. So TASE has done very well. So should we give systemic therapy? At present, post-TASE as such standard, we cannot give any systemic therapy. So, but the patient was started on atezolizumab and bevacizumab, and then 2 lesions of size after 3 cycles, patient was same evaluated. Then the size has reduced and AFP has also reduced. Then patient was continued as with atezo and bev up to 9 cycles. The CT showed no lesions after 9 cycles. Patient is on maintenance atezo bev, and on 16th cycle. This we usually see in our clinical practice, though some of the patients rapidly progress during these times because of the decompensation of the liver, and not because of the disease. Most of the times with HCC and CLD, the CLD is the killer when compared to HCC. And adverse events because of the bevacizumab, on and off hypertension, and occasional fatigue and weakness. So if you see the list of negative trials, there are n number of negative trials in the HCC. So even the best immunotherapy agents, Pembro and Nivo, they did not give great benefit. Though they are approved, they did not give great benefit. Many first line and second line failures are there. And till the lenvatinib, before that lenvatinib, there were no good drugs till many decades. Sorafenib used to be there, but sorafenib, we know its toxicity. Then came lenvatinib, then nivolumab and atezolizumab, which is now the standard of care. Second line, we have number of options, mainly regorafenib, ramucirumab, cabozantinib, pembro, and nivo. So PDL1 and VEGF, we know the synergy that we have seen in the RCC. Anti-VEGF convert the non-inflammatory medium into the inflammatory medium, and they are obviously synergistic. So this is the synergy. So cold tumor is converted into hot tumor. And IMBRAVE, which is one of the revolutionary trials in HCC, it's a phase 3 trial, atezolizumab combo in unresectable HCC. So stratification, performance score, a major vessel involvement, and baseline AFP. Atezolizumab was compared with sorafenib, which is standard of care at that time. And these MVA included high-risk patients, invasion of main portal vein, bile duct, and are greater than 50% of the liver occupying tumor. So most of the both the sites, the patients were tough patients, and median overall survival is better with atezolizumab. We can say it is doubled, and median PFS is also, we can say it is tripled, and objective response rates are also better with atezolizumab. And hazard ratios are better. Most of the times around in all the subgroups, it is 50% risk reduction for PFS, OS, and objective response rates. So if you see the time to progression also better with atezolizumab, and median overall survival for the first time, I think in HCC, this survival curves we can see median overall survival atezolizumab plus bev it is 16.4, whereas lenvatinib it is 15.8 months. And updated OS also, so it is 19.2 months with atezolizumab, 13.4 months with sorafenib. Who respond on immunotherapy, they continue to respond. And PFS is also better with atezolizumab. Updated response and duration of response. So CRs, PR, and stable disease are more with atezolizumab when compared to sorafenib. So CR 8%, PR 22%, and stable disease 44%. So safety wise, if you see, we have to be careful before starting BEV. We have to do endoscopy, and if there grade 3 varices are there, we have to do banding or ligation. That is the only important thing and special thing when we use this IO and anti-VEGF combo in HCC. Rest, we can say most of the side effects are grade 1 and grade 2. Not serious side effects, and most of the side effects we can say skin toxicity will be there with atezolizumab. And bleeding incidence is also not much different if we do endoscopy prior, and if we control the varices, then there will not be not much difference. So if you see, concluding my slides, so patient journey in HCC starts with so here we are diseasing not one disease. Here we are dealing with two diseases, that is HCC and CLD. That is most important, and correlating between etiology is most important, because hepatitis B, HCC, we have to treat hepatitis B, HCC with HCV, we have to treat HCV also. And whereas if it is NASH, then we have to see that in NASH, there is subgroup analysis that IO plus BEV is slightly inferior when compared to lenvatinib. And definitely we should not forget the loco-regional procedures, which can do wonders if the patient selection is better. And synergism is on the way. So at present it is not yet standard, but it is on the way. And right time to switch, so we know that TACE and TARE are bridging procedures for transplant, and the right time to switch from the loco-regional to systemic therapy. And upfront systemic therapy as a neoadjuvant also may come. At present it is not the standard of care. Thank you.
Hi, am I audible?
Yes, ma'am.
I have a couple of questions in this particular case. Which was just discussed before.
Yes, madam. Yes, yes.
Yeah. Hi, Dr. Sanat. Uh, am I audible?
Hi, madam.
Yeah. Hi.
Yes, 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 ma'am.
Yeah, Dr. Sujana here, this side. I'm one of the oncologists.
Yes, ma'am.
So I have a slightly different take. I know that the slides have been provided by Roche here. I have a just slightly different take in this the treatment approach. I agree that systemic treatment is definitely have to be added in BCLCB. But I don't know why. First thing is I don't know why liver transplant has not been considered in this particular patient. So it's a multi-centric. So eventually, the cure, final cure, and the final landing path for him would be an ideal liver transplant. If his AFP is also not very high, so provided if he has a donor, I think that would be one option. If you look at the case, the TACE has failed. Once the TACE has failed and the lesion has not really responded, one lesion has definitely not responded. The one lesion has only 50% of response.
Twice the test was done.
Yeah. That's what. Irrespective of that, I think it was started on systemic, but I think adding one
Correct,
more
correct.
local treatment would have been ideal in this particular patient, like SBRT or anything, because the local controls are definitely way far superior with SBRT compared to TACE. So like I said, after local treatment, if the patient is still waiting or on a transplant list, definitely adding IO and BEV would be better. But still, a local treatment definitely takes precedence here. So yeah, just that's what I wanted to emphasize.
Sure, madam. Sure.
Yeah.
Okay, thank you so much, Dr. Sanat sir. Is there any question? Okay, so move ahead. So I would like to invite Dr. Arif sir to give his talk about best standard of care of metastatic SCC. So it's over to you, sir.
Good evening, everyone. So are my slides visible?
Yes, sir.
So I will be, as Sanat has already given a brief overview of the recent approaches in the treatment of advanced SCC. I will be presenting the current evidence and looking at the future directions now. So current evidence, what we know till now, it's like sorafenib it was only sorafenib till now, till 2017. Now in the recent years, we have seen many drug developments. Actually, we are confused now to which regimen to be given to the patient. I will be doing some critical appraisal of the frontline treatment regimens. So which one is better according to the statistical analysis? Maybe clinically and real world scenario, we don't have much evidence to say. We are more comfortable with Atezo-Bev now. We have been using it for a long time. Many of our patients benefited with it. But the new drug in the blog is like Durva-Tremi. Whether we should be using this or not, what is the critical appraisal of these trials? I will be going into that. So just a brief background now. So Reflect trial, it was actually Lenva versus sorafenib non-inferiority trial. Lenva was shown to be non-inferior to sorafenib, though minimal improvement in the survival and overall survival and PFS, but it showed the non-inferiority which it was designed for. It was powered for to show the non-inferiority, and it showed that benefit. So minimal improvement survival, we have been using lenvatinib in our patients. Some of the patients benefit well with this drug. So it's a huge improvement in the drug landscape of HCC. Later on came the nivolumab was the first immunotherapy. This trial was into the news. It was a randomized phase 3 trial, nivolumab alone versus sorafenib in advanced SCC. The primary endpoint was overall survival. It did not improve the overall survival, though there was a numerical improvement there. The hazard ratios were not significant. The p-values were not significant. Statistically, we can say a negative study. and the overall response rate was also not so high, just 15%. So this was considered to be a negative trial, and this nivolumab did not receive the approval in the first line setting. That's how we moved there from nivolumab to immune checkpoint inhibition combinations. So we sort of combined the, because HCC we know is a hypervascular tumor, a lot of angiogenesis going on in the within the tumor. It is surviving on the blood supply. So why not block the blood supply to the tumor and combine with some immune checkpoint inhibitors, which can activate the immune cells, leading to better tumor cell kill. So that's what they studied. So ISI, the immune checkpoint inhibitors with anti-VEGF monoclonal antibodies, that is atezobev combination, immune checkpoint inhibitors with anti-angiogenic TKIs like lenvatinib, sorafenib, cabozantinib, all those TKIs which are anti-angiogenic, and the dual checkpoint inhibitors like nivo, ipi, durvalumab, all these were making the inroads into the treatment of HCC. Why should we combine this? So angiogenesis is very important for the survival of the tumor. So if we give anti-VEGF agents, so it causes vessel normalization, and this acts in a synergistic way with the immune checkpoint inhibitors in a better tumor kill. So vessel is normalized. There is no more and more infiltration of the immune cells into the tumor microenvironment. This leads to a better tumor cell kill. So at this, ICI activates the immune cells, and the anti-angiogenic agents normalize the vasculature, thereby causing more of infiltration of these immune cells into the tumor area, causing better tumor cell kill. So I am brave. We know all about this. So basically, a phase 3 trial, which was stratified according to the region, performance status, presence or absence of macrovascular invasion or extrahepatic spread, EFP more than 400 or less than 400, all metastatic or advanced HCC not amenable for any loco-regional therapy, without any prior systemic therapy, and all good liver functions. Those who had a fair liver function were included in this trial. Child B was excluded, though we use it in our practice because real world scenarios are different. Endoscopy was done to rule out the varices. The endpoints were OS and PFS, co-primary endpoints. Atezobev versus sorafenib. Treatment was continued till loss of benefit or toxicity. So let's see the results. So these are the updated results, 19.2 versus 13.4. Huge improvement in the overall survival, significant hazard ratio 0.6, significant p-value. The delta is maintained throughout the follow-up here. So at various endpoints, we see the good delta between the two arms here. And PFS was also significantly improved, hazard ratio 0.6. So this trial served as a benchmark for the efficacy in the first line. So it improved the OS, improved the PFS, improved the response rates. The response rates of 30% were never seen in HCC before. So this trial, it was a landmark trial, practice-changing trial, which led to the immediate approval in the frontline setting. We can see also the response rates of 30%, CRs of around 8%, PR 20%, stable disease 44%. Median duration of response was 18.1 months. I want you to just remember these figures because I'm going to compare it with durvalumab. What are the numbers look with the durvalumab? Though we can't do a cross-trial comparison, we are not going to have any randomized trial between these two regimens. So when we want to decide which treatment to be given, which regimen to be given, both are equally good, whether there are some differences or not. That's what I'm going to discuss here. So the I am brave, we know that it also improved the quality of life. So it was quality of life was maintained, not much side effects with this regimen. It improved
across all the areas. So it improved the social functioning, cognitive functioning, it reduced the side effects. So all the symptom score were reduced. So it maintained a decent quality of life to the patients. So that's very important here. And coming to it, all started with the dual immune checkpoint inhibitors after immune checkpoint inhibitors along with VEGF TKI. So after that, they moved on to dual checkpoint inhibitors. They did a phase 2 study here, Durva with Tremi. They tried different dosage regimens, different schedules. Then they concluded that uh, Tremi 300 mg with Durva yielded a reasonable responses around 24%. It improved the survival also. As we can see, 18.7 months was seen in phase 2 study. So they thought of trying this regimen and these dosage schedules in the the phase 3 trial. So Durvatrami Himalaya trial, we know that it has already, this regimen has been approved in frontline setting. When just have a briefing about this trial, that Durva Tremi versus Sorafenib. So phase 3 study, again, the design looks pretty similar to I Am Brave. So now stratification factors, all the inclusion criteria were similar to Atezo-Bev trial, and they studied the STRIDE regimen, that is tremelimumab only one dose, followed by durvalumab every 4 weeks, which was compared with durvalumab and sorafenib. So STRIDE was compared with sorafenib, and Durva was compared with sorafenib. So they what they have done is a hierarchical testing here. So once the superiority of OS is proved of the STRIDE regimen as compared to sorafenib, then they move to prove the non-inferiority with respect to overall survival when durvalumab compared with sorafenib. Then they moved on to prove the superiority of overall survival of durvalumab as compared to sorafenib. Then the last testing was to see the OS rate at 36 months. So primary objective was to see the overall survival of STRIDE versus sorafenib. Second, rest all were the secondary objectives. So we can see here that not so separation of the curves here. So the almost overlapping curves here in the overall survival, 16 months, 13 months. The HR is also 0.78, and with Durva it's 0.86, and PFS is not improved. So it's lesser than sorafenib. So we need, in our real world practice, we need responses and also patients to remain progression free. We obviously want the patients to live longer, but we also need these patients to live progression free. So progression free survival endpoint was not met in this trial. So overall survival was significantly improved, hazard ratio of 0.78. The second hierarchical testing which they had done, the endpoint of proving the non-inferiority of Durva with sorafenib, that was also met, but they could not prove the superiority of single agent Durva with as compared to sorafenib. That the third hierarchical testing was not met in this trial. Again, they updated the OS here, the 4-year updated OS. So pretty similar overall survival here. The delta, now these curves have started separating. Previously they were overlapping, but with the prolonged follow-up, now we can see the delta is getting bigger and bigger. So now the tail of the curves have plateaued here. And Durva, almost similar curves, they are overlapping. Initial phase up to maybe 10, 12 months, there is overlapping of the curves. So now coming to the critical appraisal, I want to draw your attention here that as we remember, the Atezo-Bev, this progression-free survival was significantly improved. We did not see any PFS in the Durva-Tremi. That is one point which I want to highlight, that PFS benefit was not seen in Himalaya, and the regimen seems to act at a later time period. Once we give the treatment for maybe around 8-9 months, then the survival curve starts separating. So we need to give this regimen for a longer period. That is not the case with I am brave. The curves have started separating very early. So even after 2-3 months, we are seeing the survival benefit and the responses and the improvement in the progression-free survival. That is not the case with Himalaya trial. And also the survival hazard ratios are very high in Himalaya as compared to the IM Brave. So if you want to do a cross-trial comparison, we have to compare the hazard ratios. We can't compare the median survivals. That is not fair to do so. But when we compare the hazard ratios, definitely the Atezolizumab has edge over the Himalaya trial. So 3 points here. So hazard ratio is better in Atezolizumab. The PFS is benefit was not seen in Himalaya. Only OS benefit was seen. It was the trial power to see the OS, and also when it has a long duration to act. So when we give the regimen, we have to give it for at least 6-7 months to see the benefit. So most of the patients who are higher tumor burden, they already have a widespread meds. We don't have time. So it's if you want a fast acting regimen, then we should be using Atezolizumab, not the Himalaya one. So it takes time to act. It may be the patients may live longer, but to get the immediate responses, we want the patients to feel better, symptomatically better. They want to be progression free. For all those endpoints, Atezolizumab should be considered as the first line regimen as compared to Himalaya. So again, the adverse events in Himalaya are not pretty much different. So immune adverse events around 12%. All the drug related adverse events around 17%. It also maintained the quality of life. The time to deterioration to quality of life was around 7.5 months. It was pretty similar to Atezolizumab. So now we can just conclude that if you want a faster regimen to act, that Atezolizumab should be considered in the first line because of the hazard ratios, because of the early separation of the curves, and also if you want a progression-free survival, Atezolizumab should be considered in the first line. And the other trials like ICI combined with TK was also studied. All have proven to be negative. Cosmic 312 Atezolizumab with Cabo. It improved the PFS but not the OS. Leap 02 again Pembro Lenva. No difference in OS or PFS. Other combinations which are not accessible in our country. So Camrelizumab is a Chinese trial here. Camrelizumab, Rivaroxaban. So we are not be using this. It's difficult to access the drug, though they have shown a significant improvement in the efficacy, survival, everything, but these drugs are not accessible. So first line recommendation according to NCCN guidelines, Atezolizumab or Durva-Tremi. So I have given the reasons why to choose Atezolizumab as compared to Durva-Tremi. If you want a PFS, you want faster responses. If you want early separation of the survival to be most of the patients to be progression free, then we should consider Atezolizumab as the standard treatment of choice as compared to Durva-Tremi. So again, this slide just summarizes the conclusions that if the patient, the only area where I want to use Durva-Tremi is if the patient has higher bleeding risk. So this is the patient where I would consider Durva or Tremi as the treatment of choice as compared to Atezolizumab. The rest in all of the patients, I would consider Atezolizumab as a treatment of choice. There's some the treatment is moving forward now. We have very recently many of the trials are going on. We are moving to anti-HIT agents, cell therapies, tumor vaccines, antibody drug conjugates. This is all the new recent developments we have recently seen in ASCO 24 about the checkmate 9DW. Again, a dual checkpoint inhibitor as compared to sorafenib and lenvatinib. The preliminary results have shown some efficacy. So the treatment choices are going to broaden in the future. Again, it leaves to the wise judgment of the treating physician according to the critical appraisal which regimen to be chosen or not. So the atezolizumab, tiragolumab is the one study which is going on in the phase 1 trial. Tiragolumab is anti-TIGIT antibody. It basically activates the immune system. It activates the atezolizumab to act in a better way, improving the tumor cell immunity. So again, size skyscraper, this is one study going on. The results are yet awaited. So the treatment options are going to broaden in the future. And cell therapy, CAR T cell, it has been proven beyond doubt in hematological malignancies, but it is now being considered in many of the solid malignancies that is proven to be correct in also in the HCC here. The CAR T cells, again, the phase 1 studies, multiple CAR T products are being still tested in the phase 1, phase 2 setting. We also have some trials where to guide the management after receiving immunotherapy in the first line. So whether we can use the same immunotherapy in the second line, that is also a question. This trial is going to answer that question in the maybe in the near future here. So with this, I conclude my talk. What I want to say is that given the choices of treatment in the first line, many of the immunotherapy regimens which are available, atezolizumab still has an edge over the other the regimens in respect to PFS, response rates, early suppression of curves, and also the improvement, faster action with this regimen. Thank you all for your patient hearing.
Okay, thank you so much, Dr. Arif. Is there any question to Dr. Arif? Okay, so thank you so much. And move ahead, I would like to invite Dr. Soumya TR and talk about myths and facts about immunotherapy. So it's over to you. Ma'am, can you please unmute yourself?
Can you hear me now?
Yes, ma'am.
I hope my slides are visible.
Ma'am, your slide is visible. One system you have to mute, please. But now your voice is not audible.
Okay, I'm unable to close the audio from desktop.
Okay,
Can you mute
please
one audio
mute.
from your side?
Yes, ma'am. Anything else?
मैम के ना डेस्कटॉप से भी वॉइस आ रहा है तो वो थोड़ा मर्ज हो रहा है टेक सपोर्ट सो कैन यू प्लीज हेल्प आउट
मैम आपने जब प्रेजेंटेशन शेयर किया तब आपने मैम ऑडियो ऑन कर शेयर किया है साथ में.
मैम प्लीज म्यूट इन योर डेस्कटॉप
Desktop is muted. Now can you?
Now I can hear you.
Yeah. So I'll be discussing about myths and facts of immunotherapy in HCC.
सॉरी टू इंटरप्ट मैम, आपका जो डेस्कटॉप है उसका वॉल्यूम मैम, स्पीकर का वॉल्यूम जो है वो पूरा 0 कर दीजिए मैम।
That's not being possible actually. Just a second. Sorry for interruption.
Hello, Dr. Soumya.
Just trying to share it through phone only. Just a second.
Okay, sure, ma'am.
Can you see my slides now?
Yes, ma'am.
So I'll be discussing about myths and facts of immunotherapy in HCC. So as we all know that immunotherapy for HCC has become the standard of care and has been approved by various communities like ASD, ESMO, Clinic of Barcelona, INASL, everything has approved that immunotherapy for HCC is the standard of care now. It was Dr. James P. Allison who identified CTLA4 and Takasu Honjo, and both were jointly awarded Nobel Prize for Physiology in Medicine, for Physiology and Medicine in the year of 2018. So coming to one of the main risk factors, main myth about immunotherapy and immune checkpoint inhibitors, it's a common conception that immune checkpoint inhibitors are only expressed by cancer cells. The fact is it's not. The immune checkpoint inhibitors, the checkpoints are expressed by normal cells as well. These are the physiological breaks and that are expressed on all cells and are part of normal immune system. They prevent immune response against their own cells. The cancer cells dysregulate these cells and develop immune resistance. So when PDL1 binds to PD1, it inhibits T cell killing of the tumor cells. So what the immunotherapy does is either it blocks PDL1, which is expressed on the tumor cell, or PD1 that is expressed on the cytotoxic T cell, making the tumor cell prone to destruction by the T cell. Similarly, CTLA4 also, it is expressed on T cells. It protects against T cell destruction of the cells. When CTLA4 is blocked, it makes the cell prone for destruction by T cells. And the second myth is immunotherapy is only palliative measure. And from IMBRAVE study, we see that response according to RECIST criteria, there is disease control rate of 73.6%, compared to sorafenib, which showed 55.3%, and ORR was 27.3% versus 11.9% in sorafenib as per RECIST. And according to M-RECIST criteria, it was ORR was 33.2% versus 13.3%, which is seen with sorafenib, and disease control rate was 72.3% versus 55.1% with sorafenib, which is statistically significant. And now the neoadjuvant immunotherapy has been given to bridge the patient to curative therapy and achieve complete pathological response, especially in patients with the BCLC-A and B stages. In the end of this during the end of this presentation, I'll be discussing about patients who have achieved complete response with immunotherapy and have undergone transplant. So it's not just palliative. Now the trend is changing to be curative treatment. And adjuvant immunotherapy after curative therapy, like hepatic resection for HCC, to prevent recurrence and prolong the survival, immunotherapy has been given as an adjuvant therapy also. And palliative treatment has been given to prolong survival and keep the disease under control or keep disease free in case of BCLCC. The next myth is that the etiology affects tumor response. It is that in patients with NASH-related HCC, the frequency of T regulatory and CD8 cells strongly express CTLA4, and in NASH, and it was a concept. It was a conception that NASH limits the anti-tumor surveillance in immunotherapy-treated HCC. However, both IMBRAVE and Himalaya 3 trials showed that even NASH-related and non-viral etiology of HCC had much better overall survival and PFS when compared to sorafenib therapy in patients with advanced HCC. And fallacies about these studies that are that anti-PD-L1 may not work. However, combination therapy, whether it works or not, were not assessed. And diagnosis of pure NASH in clinic is difficult, and a lot of these patients can have overlap with alcohol diseases and other diseases are commonly seen. So the clinical diagnosis of NASH-related HCC alone and not administering atezolizumab combination may be disadvantageous in these patients, and therefore it is important to initiate treatment with immunotherapy and switch to second-line treatment immediately if it is found effective. So based on etiology alone, to avoid using immunotherapy in patients with NASH is not recommended. So this is a study done by Dr. Kulkarni et al. At AIG. And even in this study, the non-viral etiological group had good overall survival and PFS. And it's a meta-analysis, and comparing many studies showed comparable efficacy in viral and non-viral etiologies with immunotherapy. And it's a myth whether it is to be given for only BCLC C-stage disease. The IMBRAVE study included all untreated HCCs belonging to child category A and ECOG performance of less than 2. Atezo combination at a dose of 1200 milligram of atezo plus bevacizumab at a dose of 15 milligram per kg was administered, and it was the effect was compared with the sorafenib 400 milligram twice daily administration, and CT or MRI was done to assess the response. And the combination immunotherapy was found to be beneficial across all child POC categories of HCC, where may it be child POC A, B, or C. And it's a myth that survival is only a few months with systemic therapy. According to BCLC staging and response in the year 2016, the systemic therapy had overall survival of approximately 10 months only. However, with the advancements in the systemic therapy options, with the advent of immunotherapy, the systemic therapy has proven to be beneficial up to 2 years in patients with advanced stage of HCC, and comparable benefits with the newer tremelimumab and durvalumab combination also. And it is a myth that there is no long-term survival associated with immunotherapy. Dr. Arif had just discussed about the benefits of the STRIDE protocol, that is Durva and Tremeli combination. And the combination has been proven to be efficacious with the improvement of overall survival in patients for up to 4 years also who have been under follow-up. However, the benefits are expected to be more at the later stages of treatment than in the earlier stages of the treatment. It's an immunotherapy. The next myth is that immunotherapy cannot work in patients with high tumor burden and extrahepatic mets. So this is this data has been taken from the IMBRAVE database. So atezobev has been shown to be more beneficial in patients who have had microvascular invasion and portal vein thrombosis and extrahepatic spread compared to sorafenib in combination, and with benefits in both median OS and PFS and better overall response rates, which is clinically significant. This is one of the patient who took treatment under Dr. Kulkarni at AIG. So this patient had multiple well-defined arterial phase enhancing lesions in both lobes of liver, with segment 8, segment 4 and 5 of liver, showing washout in portal and delayed phases, and evidence of FDG with contiguous filling defects and tumor thrombus seen in the left portal vein and its branches, extending to main portal vein and right portal vein, suggestive of multicentric HCC, and there was a large FDG with lytic lesion with soft tissue involvement and multiple bone mets, suggestive of metastatic etiology. And his AFP was 912. There was a significant reduction in number and size and enhancement and metabolic activity of most of the prior noted FDG with multiple well-defined APHE lesions in both lobes of liver, and complete metabolic resolution in prior noted FDG with tumor thrombus within left portal vein and its branch. It was near complete metabolic resolution with significant interval reduction in size of soft tissue component in a prior noted lytic lesions involving skeleton. And there were no interval new lesions or metabolically active lesions noted, indicating that even patients with extrahepatic spread and vascular invasion are candidates to receive immunotherapy, and it works much better than oral TKI options. So according to this study done by Gion et al., which was published in Liver International, based on the organ-specific response, even lung, lymph node, and other distinct organs like bones had better efficacy compared to sorafenib when immunotherapy was administered. Coming to the next myth, whether immunotherapy works only with younger population. This is a multi-center study done by Michael Vityatil et al., which was published in Liver International in the year 2022. So they studied two categories of age groups, that is age less than 65 years and age more than 65-year-old. And patients with both age groups had comparable benefits, and the survival was much better compared to sorafenib group, and progression-free survival in both age group who received immunotherapy was comparable. So atezo and bev is safe across all age groups, and even coming to this database, data set, which is taken from subset analysis of IMBRAVE, when different subsets of ages are considered, that is, say, less than 65, 65 to 75, and more than 75, and compared the efficacy of immunotherapy versus sorafenib in every age group category, immunotherapy was superior to sorafenib therapy alone. Coming to the next myth, whether we need to continue atezo-bev for lifelong. 80% of patients treated with atezo-bev achieved 30% response, either complete response or partial response within 4 doses, and another 20% by 6 doses. The study done at our own center showed that CR or PR was achieved anywhere between 1 to 15 cycles of immunotherapy. And next is whether immunotherapy causes risk of variceal bleeding and how to manage patients with tumor thrombosis. So bevacizumab, as we all know, has been available since 2004, and bleeding is unusual, but it's not fatal. And patients with varices can be treated either with non-selective beta blockers like propranolol or carvedilol or EVL. So variceal bleeding is seen in 4 to 7% of patients with atezolizumab therapy, and bleeding is similar between child A and child B categories of patients. And higher bleeding is usually higher in patients with a main portal vein thrombosis, and bleeding is similar irrespective of which type of prophylactic therapy we choose, that is band ligation or non-selective beta blockers. Coming to immunotherapy related adverse effect, is nearly 10.2% bleeding is observed with atezolizumab. As per IMBRAVE study, the bleeding risks are similar between immunotherapy group and sorafenib group. The AASLD guideline statement says that patients considered for atezolizumab should undergo endoscopy to upper GI endoscopy to assess for high-risk stigmata of variceal or other GI bleeding, and the optimal treatment for large varices prior to atezolizumab and bevacizumab combination initiation is still unknown, although AASLD recommends at least one session of banding, and carvedilol may be considered an alternative for the management of varices prior to immunotherapy. Patient with recent bleeding within 6 months and those with high-risk stigmata of bleeding with on EGD should have their varices adequately treated prior to immunotherapy. And method is you cannot prevent variceal bleeding. The recommended dose of atezolizumab combination is 1200 and 15 milligram per kg body weight respectively. And some of the studies have used low dose of bevacizumab as low as 5 to 7.5 milligram per kg body weight, and one study fixed the dose to 500 milligram per milligram of bevacizumab, and especially after the first episode of bleeding following the immunotherapy, reduced dose of bevacizumab has been found to be effective in preventing subsequent episodes of bleed, and prescription of beta blockers and simvastatin can be done if mean arterial pressure is in a acceptable range. Avoid EVL ligation in patients with main PVT. The myth is that you cannot perform liver transplant after immunotherapy, and PD-1 inhibitor as a bridge therapy to transplant has been tried in many studies. There are certain case reports I'll be mentioning here, and one case report done by Dr. Chaulik at France showed that a 57-year-old male who was an alcoholic had HCC, and childbirth category of cirrhosis was A, and belonged to BCLC B category, and his AFP was 379 at baseline. He received 18 cycles of immunotherapy, however, developed liver failure after 18 cycles of immunotherapy. He didn't have any prior local regional therapy, and patient had a 3 months gap between the last dose of drug administration and transplant, and AFP at liver transplant and MRESIS criteria based imaging showed that there was AFP of 5 nanogram, and there was complete response to the disease, and indication for transplant in this case was liver failure. And biopsy explant showed that there was complete necrosis in the 2 persistent avascular nodes, and there was no active lesions. And the patient had followed up to 10 months post-transplant, and there was no rejection or recurrence following liver transplant. The second case report was a 63-year-old male who had HCV-related CLD, had AFP of 79 at baseline, and belonged to BCLC C category and childbirth A at baseline. And he had received 8 cycles of atezolizumab combination therapy. There was no adverse event of the drug, and He had received conventional days prior to the surgery, and there was 6 weeks time gap between the administration of drug and liver transplant. AFP was normal at transplant, and there was partial response based on the imaging. An indication for transplant here was presence of HCC. And explant showed 5 small active lesions, and patient followed up for 1 year, and there was no rejection. However, the patient had HCV relapse post transplant. Another case study at USA, patient was a 66-year-old male, had HCV-related cirrhosis, which belonging to child Pugh and BCLCC category of HCC, and AFP at baseline was 43.9. He had received 6 cycles of immunotherapy with no adverse effects and no prior LRT. There was 2 months time gap between the last dose of drug administration and transplant. The indication for transplant here was again HCC and active HCC. The explant showed an active lesion of 3.3 centimeter, and the patient followed up to 1 year with no rejection features and no other adverse effects. Coming to our AIG experience, 12 out of 115 patients who received immunotherapy were downstaged. BCLC-B were out of which 5 belonged to BCLC-B category of HCC, and 7 had BCLC-C HCC, and 4 people had received local regional therapy. 3 died on wait list, and 3 waiting liver transplant. There were 4 LDLTs and 1 DDLT and 1 resection following atezolizumab. The time to transplant is 80 days. 4 patients had negative microsatellite instability and low tumor mutation burden. And 1 patient had third promoter mutation and TP53 mutation, which are considered poor prognostic markers for HCC. AFP was more than 400. Baseline AFP of more than 400, none of the patients had, and median follow-up was 10 months. And wound-related complications are common in these patients, probably due to bevacizumab affecting the wound healing. The next myth is whether immunotherapy has to be administered at any particular time of the day. Some of the analysis where immunotherapy was given for lung cancer, RCC, melanoma, urothelial, and esophageal cancers, the pooled analysis of these studies revealed that early time of the day had longer overall survival and PFS compared to late time of the day. The possible reasons could be circadian rhythm and corticosteroid levels in the body. So, to summarize, with immunotherapy, complete response is not uncommon. Excellent overall survival and bridge to liver transplant is feasible. And it's a myth that it is not economical. Only problem is it's not economical, it's not easily available, and unusual adverse effects. So with this, I would like to thank Roche for giving me this opportunity and providing the educational content, and thank you all for patient hearing.
Thank you so much, Dr. Soumya. So, is there any question? Okay, so move ahead. So, I would like to invite Dr. Veni Sethi sir and talk about ideal patient selection for immunotherapy. So, it's over to you, sir.
Yeah, good evening, everyone. Hope voice is audible and my slides are visible.
Sir, yes, your voice is audible. Yeah.
Okay.
Slide
So
is visible.
yeah. So because after an elaborate discussion of HCC along with the evidence on based upon the eligibility of immunotherapy, and secondly the facts and myths on the IO regimens. So ideally in the practical scenario and the real world data, who will be the ideal patient candidate who can receive the immunotherapy? So I'll be just touching brief on the previously talked about the IMRA 150, the real world evidence, then who will be the ideal patient based upon the real world evidence. So what does IMBRAVE 150 say? So this was a study in which was a phase 3 trial where the combination of atezolizumab and bevacizumab has been introduced for unresectable HCC. So things which has to be concerned here is basically they have taken locally advanced or metastatic or an unresectable HCC without any prior systemic therapy, and they have stratified based upon the region, the ECOG status, the microvascular invasion, and the baseline AFP, and they have randomized into 2:1 open label. Important thing here is patients have been taken only with CTP-A and CTP-B were not included. And also specifically patients who had high-risk varices previously have been banned, and patients who have bled also have been excluded based in this trial. So in this trial, you can see the baseline characteristics. When you can see that only child A and A5 and A6 have been included and no child B has been taken. And more than ECOG 1, their patients are not included in this study. But on the other end, they have even included BCLC A and B along with C. But C making up the most of the proportion of the patients, but A and B also have been included, which showed the adequate response. They have included etiological wise, but they have not included NASH as a separate entity, but they have made it as a non-viral etiology, which could be of any etiology other than the virus. And based upon the study, when we see there is a significant progression-free survival, additional advantage compared to sorafenib, and also an update has been published, showed almost an overall survival, median overall survival of 19.21, which was significantly higher when compared to sorafenib. So few important things which when you do the subgroup analysis, which have to be taken in consideration are these 4 points where we can see the BCLC-B, where we did not show advantage when compared to sorafenib there. Patient with non-viral HCC had very minimal significant advantage. Patient with more AFP more than 400 a little advantage, and patients also with no evidence of EHS or microvascular invasion have a lesser advantage when compared to sorafenib. So this was the final outcome, what was from the study, that one as a first-line resectable, unresectable HCC, when you give atezolizumab as 15 mg per kg and bevacizumab, after optimization, it can be concluded that the better outcome was seen based upon the study was a childhood class A liver disease, ECOG score 0 to 1, and HBV/HCV etiology. It was not inferior, although it was found to be non-superior in patients with non-viral etiology, BCLC stage B, higher AFP level, and no macrovascular invasion. Then further, how does the real world data say? So this is included almost from USA, Europe, and Asia, which include almost 433 patients, and 296 patients were included in the analysis. But here also you can see that ECOG performance 2 and 3 are excluded, and the childhood B and C both are excluded. And also, if it is not as a first line, that also has been excluded. But here they have taken into consideration one more score, which is the ALBI score, where almost majority of patients are in ALBI 1 and other patients are in ALBI 2. ALBI 3, no patients are there. Similar to IMBRAVE 150, the AB real data real study also showed a significant increase median overall survival of more than 15 months. And also the progression-free survival was similar to the IMBRAVE 150 study, which is out of 6.9 months. So what was the highlights of the AB real study? The objectives was basically the baseline characters was taken as a prognostic factors, and they also seen that they were associating the prognostic factors with the outcomes. The prognostic role of baseline characters, specifically the AFP more than 400, CTP6 versus CTP5, presence of portal vein tumor thrombosis, the ALBI grade 1 and grade 2, the radiological response, and extrahepatic spread. The overall survival was independently associated with baseline ALBI grade and portal vein tumor thrombosis, and shorter progression in survival was associated with higher AFP, which is AFP more than 400, worse ALBI grade 2, and a presence of extrahepatic spread. So worse ALBI, presence of extrahepatic spread, and AFP more than 400 had a shorter progression-free survival compared to patients with AFP less than 400, better ALBI score, and absence of extrahepatic spread. So in the AB real study, the overall response rate was 30.8%, the disease control rate was 77%, and overall response rate is a surrogate value of the survival benefit which has been taken. And when you see the bleeding risk, they were overall 8.4% with esophageal viruses being the most common site. So what is different from IMRA 150? That patients with non-viral etiology had comparable outcomes compared to the viral etiology. Also, this has been seen even in the Himalaya trial that the survival benefit of dual checkpoint inhibition was preserved in non-viral patients also. So this was the final AB real highlights, which show that the standard of care, which mirrored the IMRA 150. The eligibility of immunotherapy in advanced HCV is not universal, and patient selection is the key to optimize outcomes. So even within the child A, although we say the child A patients perform better, even within the child A patients, the presence of PVTT and a higher ALBI grade identify patients with poorer survival. So what about Indian study? We have an Indian real-world evidence on atezolizumab and bevacizumab. So in this 67 patient of unresectable HCC were treated with atibeva and assessment of overall survival, progression-free survival, adverse outcomes among the different child class were taken into consideration as a primary outcome. When you see these patient characteristics, few important things are here. The etiology of non-viral has been classified into NASH, alcohol, and cryptogenic, and hence separated NASH from other etiologies also in the non-viral category. The baseline alpha fetoprotein was more than 400, and even almost 50% of patients have more than 400 AFP. Here, even in patients with child A, B, C, even C patients were taken into consideration whether there have been some benefit or whether no benefit at all. And BCLC B, C, D, all three classes of BCLC B, C, D have been taken. When you see the overall survival as per the child per class, the child CTP-A has a significantly higher overall survival compared to CTP-C. CTP-A almost have a 21 months of survival, which is significantly higher than compared to the overall median overall survival what we see in IMRA 150. When you see in the CTP-A, the progression in survival is almost 18 months, which is significantly higher than compared to patients whom we have seen in the IMRA 150. So, but selecting the right patient is a key to success. The child PUC-C, as we can see that there is no significant benefits of 4 months and 2 months of progress in survival. So in child PUC-C should not be given any treatment. Varicose bleeding is less than feared. There were no increased amount of bleeding episodes, which you can see in the real world evidence data. And there were only 2 patients who had varicose bleed. Patient with a history of varicose bleeding and PVTT should be monitored cautiously, and UJ endoscopy in all patients should be done, but prophylactic banding in all, no. And hence, previously, as been told by Dr. Soumya, that patients with PVTT banding should be maximally avoided until unless patient had a recent bleed. So there are other studies, real world evidences, which show that the child, as based upon they have classified the overall survival based upon the child PUC classification, and we can see that as the child PUC-A has a significantly higher overall survival and progression-free survival compared to child B and child C. So even now we have told about the most of the patients are in BCLC-C, but there is also a role in BCLC-B. But in the past, it was basically any intermediate stage HCC, which are not amenable for any direct local regional therapy, such as multifocal therapy, focal, or any patients with infiltrative type of HCCs. Previously, there were multiple tests which used to be done, which used to deteriorate liver functions, and later on patients might be going into liver failure, going into taste failure or refractoriness, and patients then land up in systemic therapy. But the novel treatment regimen is any patient with HCC who are taste unsuitable. Patients should be given any sort of systemic therapy, preferably atezol bevacizumab combination, which would preserve liver function and quality of life. Based upon the marked tumor reduction, any curative conversion patient can go ahead with any curative conversion such as liver transplant, any patient with a taste, fin deep responders, and any curative options. This is called the ABC conversion therapies and cancer-free with a drug-free status. So what would be the ideal patient profile? So patient, any unresectable HCC, say BCLC-B with multinodular HCC, multifocal HCC, or BCLC-C. BCLC-B and C both are taken into consideration. The ideal patient profile is CTP-A, higher priority than CTP-B. More than CTP-8 score, it's preferably not to give because of the further progression liver disease and the short overall survival, which has been seen with CTP more than 8. ALBI grade 1 is ideal patient profile, and worsening any ALBI score has a poorer outcomes. ECOG performance 0 to 1. no evidence of any portal vein tumor thrombosis or extrahepatic spread. And when you take race and ethnicity, few studies have shown that Black may seem to have a poorer response, but further trials in the minority of population should be done. So ideal patient profile would be an unresectable HCC landing on BCLC B and C, CTP A with an ALBI grade 1 with a good ECOG performance status 0 to 1 with no evidence of portal vein tumor thrombosis, the main portal vein tumor thrombosis or the extrahepatic spread. However, few things to be taken in consideration: esophageal varices, whether to eradicate or not before therapy, because there are pros and cons. Eradication may lead to post bleed, post EVL ulcer bleed, and also because of the introduction of bevacizumab, the chances of bleeding rates might be high. That was postulated. In major studies, they have eradicated varices prior to the therapy, but it's up to the physician based upon the clinical signs, whether there are any red whale marking signs, then can undergo banding. If banding, the combination of Tecentriq and atezolizumab can maybe started after 14 days. The bleeding risk is highest within the first 10 days. Etiology, age, sex, there's no difference in difference in the outcomes after following immunotherapy. Also, patients with no myocardial infarction or stroke within 3 months are the ideal candidates, because in patients who are receiving bevacizumab, there are chances in any patient who have received who had a myocardial infarction or stroke in the past 3 months, there are chances that the patient might be having any perforation because of the severe myocardial infarction or any bleeding transformation of the stroke or the ischemic area, which might happen if it happened within the last 3 months, and hence to be avoided. And no co-infection with hepatitis B and C, which are already excluded in IMRA 150, and any role of any contraindication in patient with higher viral load has not been yet studied. And finally, it comes to the cost. Even though patient fits in all the ideal patient profile, the cost is a major factor which impedes them from giving an immunotherapy, but it has to be offered first and later on any other treatment. Finally, I would like to conclude my talk and happy to take any questions.
Thank you so much, sir.
Yeah.
So I would like to invite Dr. Srinivas Reddy, sir, to give his talk. So it's over to you, sir. Sir, your voice is not audible. Can you please unmute yourself?
So 80 to 90% of SCC patients have coexisting cirrhosis. Usually, when there is a loss of normal echostructure and microcirculation, and reduced hepatocyte mass and function, and reduced regenerative ability, which leads to portal hypertension with the reduced liver function reserve and with the reduced hypertrophic response. So if you see the impact of liver decompensation on patients, in patients with the compensated compensated cirrhosis and decompensated cirrhosis, the probability of survival is very, very less, while going towards decompensated cirrhosis. So initially in SCC, there is starting in phase 2 clinical trials in patients with HCC with 11 patients. They have given intravenous doxorubicin in the HCC, where there is showed that there is a reduced response in HCC. And if you see, when compared to the doxorubicin versus no anti-tumor therapy in inoperable HCC, which was showed that there is a survival is more in patients who has received than with placebo. So now the timeline initially from 2007, initially the first TKE sorafenib initially, now keep on going. There is a lot of drugs has came up, sorafenib followed by lenvatinib, and then atezolizumab plus bevacizumab, then nivolumab, and now there is this one. There is a lot of upcoming is coming durvalumab plus tremelimumab Himalayan trials. So according to the BCLC staging and treatment strategy, if you see the more of TKA and systemic immunotherapy, it will come mainly in advanced stage BCLC with portal invasion, with extrahepatic spread, with preserved liver function, and presence of even in HCC with B who are not fit for local regional therapy and not fit for transplant, with diffuse interfiltrative SCC, they might offer with systemic treatment. So there is a shift from local regional therapy to systemic therapy is evolving. If you see here, early BCLCB, yes, local regional therapy. If you go on to their extensive BCLCB and BCLCD due to vascular invasion, and extensive BCLCC with performance status is 1 and 2, the extensive stage SCC, where the systemic therapy is better than local regional therapy. So the first treatment modalities till now, it is showed that atezolizumab plus bevacizumab in the first line advanced in HCC, followed by durvalumab plus tremelimumab, Himalayan trials, and lenvatinib and sorafenib. So the second line is now coming is carbogentinimab or regorafenib and ramasibirumab. If you see here the pivot trials, the sorafenib for unresectable HCC, two trials, one is SHARP trial and Asian Pacific trial, where they have showed that sorafenib is better than placebo with more median overall survival is 10.7 when compared with the placebo 7.9 months in SHARP trial. In Asian Pacific trial, median overall survival is 6.5 versus 4.2 months. So this is the study reflect trial versus lenvatinib versus sorafenib, where it is non-inferior trial, which was showed that the median survival is when 13.6 in lenvatinib and sorafenib is 12.3. If you see here, the summary is first line treatment efficacy was sorafenib when compared to the atezolizumab, bevacizumab, or durvalumab and tremelimumab, or reflect trial. If you see here, more or less, the sorafenib, the overall survivability is less when compared to the atezolizumab plus bevacizumab, but when compared to the reflect lenvatinib, it is a non-inferior trial. Does IOE have limited benefits in NASH-related cirrhosis? Yes. There is a subgroup analysis which was showed that non-viral HCC showed that meta-analysis showed that immunotherapy has less improvement in NASH-related cirrhosis. So the real-world study to evaluate the survival outcomes in patients with non-viral HCC treated with immunotherapy versus multi-kinase inhibitor. This is a subgroup analysis which was showed that the lenvatinib, which was showed that when compared to the median survival, when compared with atezolizumab, is very high, 21.2 months with 12.2 months. And here, if you see the median performance, progressive free survival, even lenvatinib is 7.9 when compared with atezolizumab plus bevacizumab. So what are the optimal sequencing in second line? If you go here, these are the newer trials, Resource and Celestial trial and Reach 2 trials, which was showed that when compared to the placebo, the median survival is little bit better, 10.6 months in regorafenib, cabozantinib is 10.2 months, and ramucirumab is 8.5 months. So these are the pipeline which are second line agents. Nowadays, preferably people are using cabozantinib with a hazard ratio of 0.76 cabozantinib, and ramucirumab hazard ratio is 0.71 and regorafenib is 0.63. There is a sum of the trials where we can use sorafenib plus roco-regional therapy in BCLC stage B, which was showed that there is some survival benefit in loco-regional therapy plus sorafenib. So some of the trials, lenvatinib plus TACE versus lenvatinib alone in advanced HCC, which was showed that the median survival is more in combination when compared with alone. These are the ongoing phase 3 trials, combination with loco-regional therapy, TACE, durvalumab plus TACE versus durvalumab plus bevacizumab. These are the ongoing trials. Still, recruitment is ongoing on. So there's a new adjuvant therapy in early stage HCC, where it was showed that the recurrence-free survival is more or less same, and it will not helping much. So what about retreatment of advanced HCC in India? The challenges are more in Indian population. So our Indian people are morely, if you see as previously Dr. Shantan told, the cost effect is very, very high in patients with immunotherapy and TKI. But our Indian populations are below poverty line. Our problem is our solution. So we need to have a multidisciplinary team, oncology and radiology, pathology and hepatobiliary, hepatology and liver transplant program, which is amendable, which is required by the patient, downstaging and then followed by transplant or downstaging followed by immunotherapy. So till now, the survival with sorafenib has increased over a period of time. Sorafenib continues to be remain a comparative arm in majority of studies even now. The lenvatinib is remain as a robust option in the first line as a TKI. Second line now it is coming as cabozantinib and regorafenib remain option for second and subsequent lines. So we need to build our own data to answer our questions. Thank you so much.
Thank you so much, sir. So is there any question? Okay, so moving ahead for the next session, I would like to invite Dr. Anand Kulkarni, sir, to give his talk. Sir, kindly close your PPT slides.
Are my slides visible? Hello?
Yes, sir.
Am I audible?
Yes, sir.
Looks like we're very fast. Thank you so much, Dr. Mithun Sharma and our colleagues, Dr. Srinivas, Dr. Arif, Dr. Sujana, for taking us through all about HCC. I think I am the last person to speak on liver transplant after immunotherapy. I'm still making actually slides. I made few slides for this, but I would be happy to answer any of the questions if there are regarding transplant after immunotherapy. So we know that there are two things about HCC. There is something called as bridging therapy. There is something called as downstaging. The gold standard for treatment of HCC are three. That is, curative options are three. That is resection, ablation, and transplant. A patient with cirrhosis and HCC, definitely, if the patient has any evidence of cirrhosis and decompensation or portal hypertension, the gold standard is liver transplant. And there are certain criteria which have been laid down to transplant a patient. There are variable number of criteria. In fact, many of the centers have their own criteria. But the gold standard still now remains to be Milan's criteria. It basically a single tumor less than 5 centimeters or 3 tumors less than 3 centimeters. This leads to a 4-year survival of 75% and recurrence-free survival of 4 years at around 80 to 85%. That is the gold standard. Here, the 4-year actual survival. Most of our studies are saying about 5 year or 10 years or 1, 3, and 5. This is 4-year survival. This is the gold standard criteria laid down for HCC to transplant a patient who has cirrhosis. But the problem with this is most of the patients, this is not relevant, may not be relevant for living donor liver transplant center, but yes, for cadaveric centers, there is dropout. It ranges between 22% to 50% due to tumor progression. Patient, even despite being within Milan's criteria, he may progress before undergoing transplant during the waiting time. And we do tend to do a local regional therapy for these patients, especially if the waiting time is more than 6 months. What we need to do, this is called as bridging therapy. You're able to see the slide over here. The patient is within Milan's criteria. You bridge this patient to transplant. This is a bridging therapy because we don't want to lose the patient. There should be no progression of the disease during this waiting period. We do offer them a local regional therapy. Which is the best local regional therapy? It is again center dependent. But obviously, if the lesions are, it depends on the tumor size and the number as well. But time and again, they have shown that ablation, radiofrequency ablation, patients who undergo radiofrequency ablation have best post-transplant survival if they have undergone pre-transplant bridging therapy with radiofrequency ablation. But this is little less relevant to LDT settings if the patient is within Milan's criteria and has a donor ready. We obviously don't wait to do, and we don't do any kind of local regional therapy. We just go ahead and do the transplant for these patients. Then what is downstaging therapy? This is basically patients who are not within Milan's criteria, who are outside of Milan's criteria. Then they are downstage to within Milan's criteria to achieve a survival which is similar to that of Milan's. This is downstaging. Again, the most definitive therapy what we have been using time and again is local regional therapy. And thirdly, there has been new enthusiasm about the use of immunotherapy in adjuvant or in recurrent setting. Adjuvant is basically which is IMRAV 050. Although there is no long-term data as of now, but it has shown that there is reduction in the incidence of recurrence-free survival for patients who have high-risk HCCs. They have laid down 4 or 5 criteria for these high-risk HCCs. Most of these patients, if you see the trial, they have undergone ablation and they had microvascular thrombosis and other multiple 4 or 5 criteria, but they are basically early tumors which are at high risk of recurrence. And they had given for immunotherapy atezolizumab for 18 months, and they showed there is reduction in the recurrence-free survival. OS is not yet achieved. But the use of immunotherapy or any kind of TKIs as an adjuvant therapy, especially in my setting or probably in Indian perspective, is less. We don't tend to add them any patient with either immunotherapy or any kind of TKIs if the patient has undergone a good local regional therapy. We just tend to follow them up. If the patient has high alpha fetoprotein or we feel that the patient has multiple tumors, we tend to add them on TKIs as and when required. Local regional therapy, as I said, is a well-established downstaging modality. It is also a very well-established bridging modality. The commonest one which we use are TACE, transarterial radioembolization, SBRT if the patient only has portal vein thrombosis, ablations for patients who have small tumors but there are multiple tumors, we tend to do them, ablation, radiofrequency ablation or microwave ablation. Again, this is all dependent on the presence of expertise at the center, the comfort with the patient and the treatment clinician as well. Each one has their own individual choices. We tend to do the TACE for patients who have larger 3 to 5 centimeters in combination with ablation. If this patient has small tumors, we tend to just ablate them. If it is somewhere near to the biliary tract or the vascular channels, we tend to do a microwave ablation for these patients. Radioembolization, if the patient has large tumors, then we tend to do a radioembolization. This is the one of the large studies on local regional treatment before transplant for HCC. This is the ELTR, European Liver Transplant Registry, published in the Transplant International Journal. There was information about 4,978 patients who had undergone local regional therapy prior to liver transplant. Again, LRT was associated with improved overall survival, hazard ratio of 0.84, and improved HCC specific survival, hazard ratio of 0.76. That is 30 to 40% improvement in survival with these patients who have undergone local regional therapy. But if you see this table over here, it is excellent bridging therapy, as I said before. Local regional therapy, yes, it is associated improved for 5-year survival and HCC specific 5-year survival. Compared to patients who had not undergone any treatment, RFA has the best therapy, followed by slightly the confidence interval has crossed 1, and TACE is the second. Resection third, that is no much difference compared to no treatment. And others as monotherapy, basically comparing monotherapy versus combination therapy. TACE plus RFA has the best overall survival compared to others who have received only monotherapy. But again, there is no addition use of using TACE plus RFA plus other modalities. So using any one modality, preferably RFA or TACE, preferably RSA, the patients have better post-transplant 5-year survival as well as HCC specific survival. The patient has undergone TACE plus RFA, again better. This basically indicates that the patients had small tumors but probably longer waiting time That's the reason they have undergone some form of ablation, which we obviously know that the patient has undergone, is eligible for ablation. He already has a good survival post-transplant and pre-transplant as well. So nothing unique, but it's a very important message here is single therapy or monotherapy or dual therapy in a combination of DS and TS and RFA will have a better post-transplant survival. But contradictory to what we have been noting, there are multiple studies in PubMed. We'll find many of them. The only one which I highlighted, the reason I highlighted was a large study, and it was from the European Liver Transplant Registry. And they also follow the EASL guidelines, where they say that Milan's criteria is the gold standard. This was a study published in Annals of Gastroenterology 2023, bridging loco-regional treatment prior to LT for cirrhotic patients who are within Milan's criteria. It's a meta-analysis, systematic review and meta-analysis. They included more than 26 or some retrospective studies. And 71% had received loco-regional therapy compared to 29% who did not receive loco-regional therapy. The most frequent type of LRT was transarterial chemoablation, radiofrequency ablation, microwave ablation, and most of the patient and tumor characteristics were similar. There was a little larger size in patients who had undergone LRT. And LRT group also had multifocal disease slightly more frequently compared to those who did not undergo LRT. It is probably very much suiting what we actually select a patient of LRT again. We see there is no difference between two arms in waiting time, dropout rates, disease-free survival at 1, 3, and 5 years, or overall survival. So whether you do a LRT or do not do a LRT, a large meta-analysis, nearly 8 to 9,000 patients, did not demonstrate any benefit for these patients. Obviously, it included many of the retrospective studies. All of them are mostly retrospective studies. A well-conducted prospective RCT is still lacking and may be required in near future. Having said that, yes, LRT remains to be a good therapy, standard therapy as of now to bridge a patient or to downstage a patient or of HCC to transplant. But the problem why we need a novel therapy is there may be situations where there is a prolonged waiting time. The individual may not be willing for transplant. There may not be any suitable donor, or the patient has other complications, other complex comorbidities, which is not allowing us to do a loco-regional therapy, or the patient is not responding to the loco-regional therapy despite doing multiple sessions. That lesion tends to be active. The patient may require multiple loco-regional therapies, or there is poor response because if the patient has poor response, any activity at least 2 centimeters in a patient who has large tumor post LRT will have poor response post transplant. There is high risk of recurrence. There is poorer survival. The patient has not responded to any LRT prior. What we need to assess is patients who undergo LRT. We need to assess their scans, MRI, and CT, and to demonstrate that the patient has complete necrosis of the tumor prior to transplant. That is very much essential. Any response on radiological response pre-transplant, complete response, improve the survival post-transplant. Why we need to find the therapies, newer therapies, that is, there is 50%, as I said before, 20 to 50% chance that they may not be successfully downstaged. They may have dropout because of the disease progression, recurrence, extrahepatic mets. And most often these LRTs do not deal with microvascular invasion or microsatellites, which is very difficult to target them. There may be cellular mutations, which we are not aware. The tumor biology may not be favorable despite doing multiple sessions of LRT. The microenvironment cannot be changed with local renal therapy. We can only change with immunotherapy or other medications. These are the reasons why we need a novel therapies for these patients to downstage them to transplant. There is excellent data regarding use of nivolumab, which has not been approved for HCC therapy. It failed because the p-value did not reach a significant value, significance less than 0.05, 0.06, or 0.07 in the landmark study. That is the reason the use of nivolumab has gone down, but there are several reports from Parisa Tabrizan from New York saying that yes, after using nivolumab, we can transplant a patient with good post-transplant outcomes. The newer drug, the approved drug which is there out of the new 2 or 3 immunotherapies which are available, one of them is atezolizumab, bevacizumab, which is available in India. This is our experience, which was published in Journal of Liver Cancer. Here, we downstage a patient who are, this is basically all comers, not only specifically related to Milan. These are all comers. Most of them who are outside of Milan's were downstage to within Milan's and then transplanted. This is the evidence for patients who have undergone transplant post immunotherapy. A small case series from our center, probably one of its unique kind from Asia. There is one case report from Bangalore by Dr. Pramod, which has been published in American Journal of Transplant. And there is also one more case report which is published in Frontiers Journal. Again, single case report. This is the largest series as of now. There have been again one more study which was published in Journal of Hepatology, which is a combination of multiple therapies. They have used all sorts of immunotherapy, and they showed that the intention to treat survival post immunotherapy ranges up to 75% in these patients who receive immunotherapy prior to transplant. There are multiple points to be to read in this slide basically. These were all comers. We had 115 patients who had come to us who received immunotherapy at atezolizumab, average around 3 to 12 cycles, 6 that's median number of cycles. 4 received prior local regional therapy. Their BCLC staging was B in 5 and C in 7. 3 patients had died. That is the major problem with our patients. We don't know the reason. This was a very unique question by the reviewer saying that whether immunotherapy increased the risk of sepsis because 2 of the patients developed SBP. Atezolizumab, bevacizumab, did it increase the risk of sepsis was a question, but we cannot answer. We don't know whether it was because of the disease progression or the liver disease progression or the drug related. It is very impossible to prove that. There are 3 patients who are waiting, 3 who had died, 6 underwent curative therapies. Nearly 4 to 5% of the 115 patients. If you convert them into a patient in HCC population, it's a huge number. 5% undergoing transplant after immunotherapy is a huge number. Curative therapy. One had undergone resection, one had undergone disease donor liver transplantation, 4 underwent LDLT. What we did was with the help of our colleagues from Roche and our friends, they helped us assess the tumor mutational burden. We did a liquid biopsy for these patients at free of cost, and we found that patients had negative microsatellite levels in this patient and also low tumor mutational burden. None of the patients had AFP more than 400 nanograms, and the median time to transplant for 80 days following the last dose. Even now, it's been almost a year since we have been following them very closely. None of the patients have developed recurrence. There is one patient who has developed mild rejection, diagnosed only clinically. We did not biopsy the patient. We just increased the dose of steroids and tacrolimus, and the patient responded to therapy. The interesting thing, what we noted here were 2 patients developed wound dehiscence. This was probably related to bevacizumab. Bevacizumab being a VEGF inhibitor prevents the healing of the wounds that leads to development of infections, or probably one also had wound dehiscence. This may be probably related to VEGF. We don't know whether we can give VEGF analogs to those patients post-transplant to prevent such complications. That is one of the hypotheses we have suggested in the paper. So 10.4% were downstage to within Milan's criteria. Out of everybody, almost 5% could undergo a curative therapy. It is excellent for our huge burden of HCC. We all see lots of HCCs day in and day out. And this has been a unique study which has been part of multiple multi-center studies in upcoming studies as well. The safe washout period, that is one major issue with all these drugs which we use. Basically, what happens when we do transplant, the risk of recurrence is high. The recurrence is because of extrahepatic mets or the vascular invasion, which again the tumor comes back to the liver and develops in the de novo liver, causing recurrence, which is a major issue with this because all these patients are on immunosuppression and the risk of recurrence increases post-transplant. So the duration, optimizing the safe washout period is most important for these patients. That's the reason we need to know the half-life of these drugs. Nivolumab is 27 days, pembrolizumab 23 days, atezolizumab 27 days. That's the reason we dose it at 21 to 28 days. Durvalumab 18 days, ipilimumab 15.4 days. So 1.5 half cycle is the shortest safe period to achieve a washout to prevent a rejection, to improve the survival post-transplant. This was a small study of 25 patients published in Transplant Proceedings. So 1.5 cycles is somewhere around, if you see 30 days, so it is 45 days approximately. The shortest, ideally it should be more than that. Most of the centers at least take at least 60 to 90 days. With the previous one, in our study, we had 78 and 80 days, and the lowest was 54 days. The 45 to 60 days at least, you have to wait prior to transplanting these patients. There are multiple ongoing trials on immune checkpoint inhibitors as a downstaging modality. This one in USA, the most important of these is Immune XXL study that is in Europe. It is a multi-center study on atezolizumab, bevacizumab. And in patients achieving more than 60% post-transplant survival according to Metro Ticket 2 is our primary endpoint. And minimum washout period in this trial planned is 30 days. There is one more study on pembrolizumab plus lenvatinib. Minimum pembrolizumab washout period is 42 days in that study. And the ESR the trial from USA is based on STRIDE regimen, which has come up, which has been approved recently, single dose of tremelimumab plus followed by durvalumab. Although not yet available, tremelimumab is not yet available, will be available in a month or so. But there are certain caveats about using of STRIDE. It has more adverse events probably. They had to still, the real world evidence is still lacking for STRIDE. The minimum washout period, if you see here, is 72 days. So the risk of recurrence, the risk of progression is little high in this, probably by using this. Let us hope and let us wait for newer ongoing trials. We'll see many more drugs coming up for downstaging these patients of HCC and improving their survival. To summarize, immunotherapy, yes, appears to be an exciting avenue for downstaging, but there is definitely more data which is needed for the use of these drugs. The most important thing, as the previous speaker said, that the cost is is a hindrance for all of us. And there have been some novel ideas which have been floating around to improve the outcomes of these patients, also while reducing the cost of the drug for these patients. Combination of local region therapy with ICIs probably will have increasing impact on downstaging these patients. The risk of rejection is definitely there because you are immunosuppressing the patient, because immunotherapy, they basically increase the immunity and kill the cancer cells. Post that, when the patient is on immunosuppressed, he may have recurrence. Typical washout period is 30 to 45 days is minimum, preferably 60 to 90 days. The choice of drug is still unknown. Observation period, whether there is a need of new biomarker, as we did liquid biopsy in our settings, which was very useful for us. One of the patient had TERT promoter mutation. TERT promoter and TP53 are the commonest mutations in HCC, but these are all non-druggable mutations. That is the problem with this mutation. One of the patients at bone mets had a reduction in the size, excellent response, but he had a TERT promoter and TP53. He said we cannot transplant. So he continued immunotherapy, but again had progression of the disease within 7 months. He's still alive. He's been there for almost 1.5 to 2 years, but we did not transplant, fortunately, because the patient has progression of the disease. The role of these drugs in LDLT, where the problem with LDLT is readily available. We don't want any bridging therapies. We don't want anything to prevent the recurrence. We want something to downstage these patients with an economical way and improve the survival of these patients. I'd be happy to answer any questions. I had a few more slides to make, but I apologize. Next time I will be much well prepared for the talk. Thank you.
Well, thank you so much, sir. Is there any question? So I would like to invite Dr. Mithun sir to give his closing remarks. So Mithun sir is there.
He must be busy in, I think he had one more meeting. No problem. I will end the session.
Okay, no. Okay, so not an issue to give his closing remarks, sir, and close the meeting now.
Thank you so much, everyone who participated in this active session on HCC. All about HCC, ranging from epidemiology, pathogenesis, local region therapy, radiotherapies and as a transplant as a final modality for these patients. And you also learned about myths and facts about immunotherapy in HCC. I'd like to thank the tech support and Healthy Blossoms for organizing this wonderful event. Good night.
Thank you so much, all the faculties, to join this webinar. And thank you so much, tech support and Roshni. And tech support, can you close the meeting?
Yes, ma'am.
Thank you.